classification. Earlier, there were separate classifications. And this classification defines disease based on their clinical features, pathological features, immunophenotypes, cytogenetics, and molecular features. So this is the WHO EORTC combined classification of cutaneous T-cell lymphoma, which was proposed in year 2005. So it has broadly three subtypes. One is cutaneous T-cell and NK cell lymphomas. Second is cutaneous B-cell lymphoma. And third is precursor hematological neoplasms. Amongst cutaneous T-cell lymphomas, there are further subtypes. One is mycosis fungoides. The other predominant part is primary cutaneous CD30 positive lymphoproliferative disorders. And the third is extranodal NK T-cell lymphoma nasal type. Further, even mycosis fungoides has a lot of subtypes. It is sometimes important to recognize these subtypes. So it can be either folliculotropic mycosis fungoides, pagetoid reticulosis, or granulomatous slack skin, or it can be a Sézary syndrome. Similarly, primary cutaneous B-cell lymphomas also has a lot of subtypes like marginal zone lymphoma, follicular center lymphoma. There is a separate category which is called as primary cutaneous DLBCL of leg type, and then there are intravascular large B-cell lymphoma. Now, this is a very important table for anyone who treats cutaneous lymphoma. This table gives a lot of information. This table tells you about various histologies, how commonly we see them, their frequency, their approximate 5-year disease-free survival, and their behavior, whether they're indolent, intermediate, or aggressive in their behavior. So let's look at some of the subtypes. For example, overall for mycosis fungoides, it constitutes 44% of all cutaneous lymphomas, and the disease 5-year DFS is around 88%, and it is considered as indolent disease. But if you look at all the variants of mycosis fungoides, we find that folliculotropic mycosis fungoides has a lower disease-free survival as compared to the general DFS of the combined mycosis fungoides group. Going further, if we look at the outcome of Sézary syndrome, which occurs in about 3% patients of cutaneous lymphomas, the survival is much inferior. It is an aggressive disease and needs aggressive systemic therapy. Going further down this list, there's another type of T-cell lymphoma which some of us encounter reasonably often, that is called as primary cutaneous ALCL or anaplastic large cell lymphoma. It is a CD30 positive lymphoma. Now, majority of us think, and medical oncologists also make us believe, that all CD30 positive lymphomas are very aggressive. While if you look at it here, the 5-year DFS for these patients is 95%. That is actually indolent in behavior. So a lot of these patients, when they will come to you, they would have a skin lesion which gets, somebody excises it outside. And if the margins are clear, it is okay to just observe them and not do anything. If they come with a definite lesions, or if there is an issue of margin, generally only local radiation therapy is enough for primary cutaneous ALCL CD30 positive disease, and no systemic therapy is required. Similarly, we must recognize that there is another entity of T-cell lymphoma, which is called as primary cutaneous CD8 positive epidermotropic lymphomas, which are very aggressive. The 5-year DFS is only 20%. These are patients who require a lot of systemic treatment. The point that I'm trying to make here is that remember that when you're getting a patient of where you're suspecting it to be mycosis fungoides, apart from the IHC markers which are required for the confirmation of mycosis fungoides, you must make sure that they are CD30 negative. They should also be CD8 negative. I will be retouching this point once again in my presentation later on also. I also want you to pay attention to this entity which is called as primary cutaneous DLBCL leg type. It has a 5-year DFS of only 55%. It is a very, very aggressive DLBCL. These patients fail quickly. Their diseases grows rapidly. So these patients require a lot of systemic chemotherapy and not just radiation therapy. So as a radiation oncologist, we must recognize these entities and reach a correct diagnosis before embarking on treatment. So since I was talking about the variants of mycosis fungoides, these are two variants that I would especially like to mention. I will show you some pictures also of patients having these lesions. In a folliculotropic lymphomycosis fungoides, it involves dermics and the adnexal structures, mainly in the head neck areas. Now, because it involves the adnexa or the hair follicle, the depth to which they have to be treated has to be carefully assessed. They need little deeper treatment than the usual mycosis fungoides, and they carry a little adverse prognosis. I have seen two patients with folliculotropic mycosis fungoides so far. There is another entity which is called as granulomatous slack disease, where there is development of fold of slack skins around axilla and groin. It is an indolent disease, and the recommended dose is 20 grain 10 fractions. So far, I have not encountered this in my clinical practice. Now, I will show you some of the pictures of how mycosis fungoides actually looks like. Dr. Rashi, is it going at the right pace, and am I audible, and are my slides clearly visible to all of you?
Ma'am, you are audible, and actually some disturbance is coming from your mic, I think. But your voice is audible, and your pace is also right.
Is it better now?
Yeah,
Is it better now?
yeah, ma'am, it is better.
Okay. So mycosis fungoides is actually considered a malignancy of helper T cells, CD4 positive cells. So whenever you are reading any biopsy report of mycosis fungoides, always focus and make sure that it is CD4 positive disease. In EORTC classification, they recommend that term mycosis fungoides should be reserved for CD4 positive cutaneous lymphomas. Now, the lesions can be either in the form of skin patch, or they can be ring-like lesion or arc-shaped lesions with mild erythema around it. The patches may progress to form scaling plaques with well-defined palpable borders. You can see that this is an arc-shaped lesion. There is some scaling on top of it. It has an erythematous but a well-defined border. But when the cells of mycosis fungoides lose their skin homing property or epidermotropism, then they start having a vertical growth, and then there is a tumor formation. So this picture is actually from an article which is showing all the 4 phases of cutaneous T-cell lymphomas. For example, this is a patch. A patch is a typical lesion which is not elevated, not indurated. This is a plaque. Look at the classical finding. This is an arc-shaped lesion, well-defined borders. This is a nodular lesion with multiple satellite lesions around and central ulceration. And this is erythroderma or generalized erythema of the skin of the body. Sometimes there can be added ulceration and infection. And classically, the lesions to begin with start at the sun-shielded areas, with the most common site being trunk, pelvis, and the proximal part of the extremities, which are generally covered and sun-shielded. This is another patient. Look at these ring-shaped lesions or arc-shaped lesions. These are classical findings of mycosis fungoides. So if you see these kind of lesions, you're pretty sure that it is a mycosis fungoides, but all the patients may not have classical clinical features. This is another patient. He presented with very thick nodular lesions. It was hard to see him. It was difficult to examine him. He had mulberry-like big, thick lesions. I will show you some more of his pictures. Also see that there is a lesion behind the ear lobule. There is a lesion in the external auditory canal as well. So a lot of these patients, in spite of having disease all over the body, have to start their treatment with a local boost to these lesions with a higher dose of electron therapy before starting the total skin electron therapy. This was another patient. He had presented with multiple ulcerated lesions over the back, and the condition of the skin of the back was quite bad. This was another gentleman. He had a lesion which had ulcerated, multiple lesions which had ulcerated. So as I mentioned earlier, my small tip to everyone is that if you see any patient who has nodular, thick, ulcerated lesions, hold TSET. Once you achieve a diagnosis, start treatment with a boost to these lesions first. It will give you 2-3 advantages. First advantage is patient will have immediate symptomatic relief. Second advantage is that the thickness of these lesions will decrease. So when you're doing TSET later on, the TSET will become more effective. Third reason why we start with boost is because sometimes after TSET, these lesions completely regress and disappear, and then it becomes difficult for you to correctly identify the borders and boost them. So we generally start any electron therapy for mycosis fungoides with the thick lesions or ulcerated lesions which require boost. Please make sure that when you're starting with boost, you use appropriate bolus or degrader to achieve the high skin doses in these patients. Now, this is another gentleman. Look at his lesion. You know, these lesions, they look like something like acne. They look like infected acne. Look at it here. His biopsy was mycosis fungoides. This, in my mind, is a folliculotropic variant of mycosis fungoides. So, the more you treat these patients, the more you see them, you learn to identify these rare subtypes also. Now, when you're examining any patient, another small tip from my side is that you have to examine and document disease in all body parts. It is better to do a photographic documentation of these lesions. Now, when you're giving total skin electron therapy to a patient in a standing position, there are a lot of areas of body which will not get the dose. For example, perineum. So you must identify these areas. So you must carefully examine these areas which are likely to get shadowed or underdosed during total skin electron therapy, especially like perineum, behind ear lobules, sole of feet, eyelids, scalp, etc. So that you should have a complete plan in your mind, complete radiation plan in your mind when you start, treating these patients. This is another patient. He had multiple lesions over his hand. Look at these lesions. These are quite typical of mycosis fungoides. Now this is another picture. This is showing you lesions on the sole of the feet. So what I find is that sole of the feet will usually have a lot of scaly patches. You know, a lot of women with these disease they will come back and say that I have a lot of dead skin in my body, or my heels keep cracking very often. And then once you treat them, once you give radiation to the sole of the feet, they will say it has all disappeared. One of the young fellows, he was being treated for viral warts in the sole of the feet while it was actually mycosis fungoides. The point that I'm trying to make here is, one is that when you're examining the patient, you have to examine from head to toe. All hidden parts of the body have to be examined. Second point that I'm trying to make is that the sole of the feet lesions are usually different than the lesions elsewhere in the body, and they are more scaly in appearance. So as I just now mentioned, the message that I'm trying to give you all is that photographic documentation of all lesions is very important. If your patients have dense scalp hair, preferably ask them to shave hair so that you can examine their scalp well. Or if they have not so thick hair, you can just separate the hair and examine the scalp. In your first clinical assessment, identify the areas which will require potentially boost. For example, any thick ulcerated lesions, any specific lesions in the axilla, any lesions on undersurface of penis or ventral surface of penis, sole of feet, eyelids, upper medial aspect of thighs. Pay attention to all these areas. So for the diagnosis of mycosis fungoides, you need to take a complete history of the patient and do physical examination of the skin, lymph nodes, any peripheral lymph nodes, and abdominal examination. For histological diagnosis, you need a skin biopsy. It should be a full thickness incisional skin biopsy. If there are any enlarged lymph nodes, you must biopsy at least some of them, one or two of them, and pay attention to the histology. There is a term called as dermatopathic lymph nodes. So dermatopathic lymph nodes, when examined by a pathologist, they may not find classical histopathology features of mycosis fungoides, but at the same time, they might just tell you that the lymph node architecture is not looking normal. It is looking as if there are some changes in the cortical and subcortical part of the lymph nodes. If there is any doubt whether these lymph nodes are positive or negative, you can do PCR for T cell clonality for ruling out occult involvement of these lymph nodes. histopathologically, there are some classical findings, and we must pay attention to these classical description of mycosis fungoides biopsy. One is epidermotropism. Second is that there are intradermal microabscesses, which are called as Potier's abscesses. On IHC, generally CD2, CD3, CD4, CD5, CD45 are positive, and CD8 and 30 have to be essentially negative. So, I generally, when I look at the report, I remember that I have to check whether 2, 3, 4, 5 are positive and 8 and 30 have to be negative. This is just how I remember it. They can be a focal CD30 positivity. That's okay. They can be a focal CD8 positivity, but it should not be a dominant or a diffuse positivity. And CD4, as I mentioned earlier, is the hallmark for mycosis fungoides. Apart from this, you also require CBC, biochemistry, LDH, ESR. Another thing which is required is that you have to rule out Sézary syndrome. For that, you have to do a flow cytometry for CD2, 4, 5, 7, 20, CD45. PCR for T cell receptor rearrangement monoclonality is a problem solving tool. I will give you two examples. I had a young gentleman, he was around 20 years in age, who was an MBBS student. He came from Russia with a diagnosis of mycosis fungoides. His lesions were very superficial. They did not have the classical appearance of a mycosis fungoides lesion, and I was not sure of the diagnosis, although his skin biopsy from 3 places was reported as mycosis fungoides. But treating somebody at the age of 20 years makes you a little nervous. So we did a T cell receptor rearrangement gene analysis for him. It came positive. And then I had the confidence of treating him with total skin electron therapy. But then I had another gentleman. His lesions were quite typical of folliculotropic mycosis fungoides. He also had a biopsy report, but when we reviewed biopsy at our center, our pathologist said that this does not have the classical feature of mycosis fungoides, and this is when we sent PCR for T cell receptor rearrangement, and it came negative, and we did not give him radiation. So I consider this as a problem solving tool. Whenever I am in doubt or there is any uncertainty clinically or on biopsy, then I ask for this PCR for T cell receptor rearrangement. Now, there are some variants of mycosis fungoides which may show aberrant loss of CD2, 3, and 5, which are usually positive. So, if you find the 2, 3, and 5 are negative, and you have any diagnostic dilemma in your mind, it is better to do this test. Essentially, bone marrow aspiration and biopsy is not recommended routinely for all patients. But if your patients have unexplained cytopenias, or if you find they have erythroderma, or if you find that they have very advanced disease, I still do bone marrow aspiration and biopsy for them. As a part of radiological workup, for stage 1, generally chest X-ray and ultrasound of the whole of the abdomen is considered adequate. For stage 2 to 4, you have to do a CCT of chest and abdomen. PET CT scan is not routinely recommended because majority of these patients have, mycosis fungoides is only mildly FTG avid and not very avid disease. But at times I find that patients walk in with PET scan to us. Now, this is another very important message that I wanted to tell you, that suppose you send peripheral blood sample for Sézary syndrome, you have to understand that there are specific criteria for calling a Sézary syndrome. And these are those criteria. And the first one is that the absolute Sézary cell count has to be more than 1,000 cells per microliter. So which means that if somebody has, say, 500 cells, it is not Sézary syndrome. It is B1. It is not B3. I will explain it to you once again later on also. So you not only have to look for the presence or absence of Sézary cell count, you have to look at the absolute count also. Second, the ratio of CD4:8 has to be more than or equal to 10. These are two very important findings which you must pay attention to when you're reading the report of flow cytometry of blood samples sent for Sézary syndrome. Then there are other factors also, and when in doubt, send for T cell receptor rearrangement to look for monoclonality. Now let's come to the staging. So the Ann Arbor staging, which we routinely use for our nodal lymphomas, is not applicable here. International Society of Cutaneous Lymphoma and EORTC have proposed a new specific staging system for cutaneous T cell lymphomas. It is not a TNM staging, it is a TNMB staging. So I'm giving you a very simplified form of staging here. So T1 is when patch or plaques are involving less than 10% of the body surface area. T2 is when patch or plaques are involving more than 10% of the body surface area. T3 is one or more cutaneous tumors. So once you have a tumor, it becomes T3. If it is patch or plaque, it is either T1 or T2. If there is generalized erythroderma, what we call as red man syndrome, then it is T4. N0 is clinically uninvolved lymph nodes. N1 is lymph nodes are clinically enlarged, histologically negative. So these are dermatopathic lymph nodes. N2 is lymph nodes are clinically not palpable, but histologically involved. N3 is when they are clinically enlarged and histologically also involved. M0 is no visceral or visceral metastasis. Now coming to B0. It is either B0 or B1. B1 is when there are no circulating atypical cells or the cells are less than 1000 Sézary cells. If they are more than 1000, then they are labeled as B1. This is a simplified TNMB classification. But actually, if you look at it, it has multiple subtypes also. I will leave it to you for reading it later on, because they have to be, for example, for labeling whether lymph nodes are significant or not, you have to do PCR for T cell clonality, and N1A or N1B is divided depending on whether the clone is negative or positive. Similarly, for B1 and further there is B2 is also there. I suggest you can go through this TNM staging later on, because we've already crossed half an hour of our presentation time. Now, when you're classifying or when you're trying to stage these patients, remember that patch is when there is no elevation or induration. But if there is any hypo or hyperpigmentation or scaling or crusting, then you have to clinically document it. If your plaques have any ulceration, ulceration is not a part of TNM staging, but it has to be documented. Abnormal lymph node is defined as lymph node which is firm, irregular, or cluster of lymph nodes, or fixed lymph nodes, or more than 1.5 centimeter in diameter. And T cell clonality is defined based on the T cell receptor rearrangement gene. Now let's look at the stage grouping. So URTC says that up to 2A, it is early disease. They call it advanced stage disease from 2B onwards. Now, stage 1A, 1B, and 2A includes T1, T2, N0, N1, N2, M0, and B0 or B1. So even if there are some Sézary cells present in blood, but less than 1000 micro per liter, then it is still B1 and does not adversely affect the stage. Stage 2 to 3 is when the lesions are either T3 or T4, irrespective of N, M, and B stage. We call it stage 4 when there is either visceral metastasis or N3 disease, or blood is showing B2 kind of staging. It is important to know these stage groupings to choose best treatment for your patients. For example, if you have a patient who's got stage 1A or 1B disease, probably you need skin directed therapy. But if your patients have stage 4 disease, then they need more of systemic therapy. And that is why it is essential to be able to stage classify them, stage group them. Now, my last slide about Sézary syndrome. Sézary syndrome is a combination of T4 plus, which means along with malignant circulating T cells. So if somebody has only erythroderma, no malignant circulating T cells, it is not a classical Sézary syndrome. The patients have to have a combination of T4 disease with malignant circulating T cells. Sézary cell is a atypical lymphocyte with folded or grooved nucleus, and usually it arises de novo. There is no history of antecedent mycosis fungoides. It starts on its own. it is extremely rare that mycosis fungoides progresses to Sézary syndrome. I hope I'm clear that Sézary syndrome patients will have a presentation with Sézary syndrome and it will not be a progression of mycosis fungoides. So coming to the prognostic factors for mycosis fungoides, advanced T stage, advanced T end stage, advanced B stage, increased LDH or folliculotropic MF, they all adversely affect the prognosis or outcome of these patients. So in this table, I have just, through some of the literature, I have just tried to summarize the median survival of these patients. If these patients have a very early disease like stage 1, then the survival is more than 20 years. Stage 3, easy to remember, median survival is 3 years. Stage 4, 1 to 2 years. So there is a lot of variation in the survival of these patients according to the stage grouping, and that is why we must stage them as appropriately as possible. Now, as a radiation oncologist, sometimes we tend to think that radiation is probably the only treatment for mycosis fungoides, while that is actually not correct. This table is listing multiple options, treatment options available for treatment of mycosis fungoides. So let me take you through some of these treatment options. For example, topical steroids, PUVA A, PUVA B, they are very useful for early stage disease. While if you look at the systemic therapy options, bexarotene, interferon alpha, HTEC inhibitors, oral methotrexate, they are useful for advanced stage or Sézary syndrome. Now, the problem is that some of these drugs are not easily available or they're very expensive. Because I have been treating this disease for some time, I have realized that very few patients can get hold of these drugs or financial patients. And these therapies, or in TSET, in mycosis fungoides, these therapies are generally used as second line or beyond second line. Well, let's look at the role of place for radiation therapy. So we find that localized radiation therapy or TSET is effective for early stage disease as well as advanced stage disease. Sometimes even patients who have Sézary syndrome or erythrodermic mycosis fungoides also require total skin electron beam therapy for the purpose of quick palliation of their cutaneous lesions. Now, please pay attention that this list of treatment has no mention of shock chemotherapy, which a lot of medical oncologists keep giving for these mycosis fungoides patients. It has no role. It does not work. It is a complete waste of time to give shock therapy to a patient of mycosis fungoides. In this nice flow chart, they've again depicted what stage of mycosis fungoides needs what treatment. I will just take you through that. So if the patient has limited patch or plaque kind of disease, you need skin directed therapy. For example, local steroids, local retinoids, PUVA A, PUVA B, or local radiation therapy. If it is stage 1B to 2A, then these patients, when they have generalized patch or plaque or T2 kind of disease, again, they benefit from skin directed therapy, either topical or PUVA or total skin electron therapy. But once it is stage 2B, which is T3 disease, they need combined modality treatment, which can be, if there are few discrete tumors, you may give them radiation followed by PUVA therapy. If there are generalized disease, you give them total skin electron therapy followed by adjuvant PUVA A or oral retinoids or oral methotrexate. If it is erythroderma or 3B disease, then these patients require more systemic therapy and SOS total skin electron therapy. For if they have visceral involvement, again, they need more systemic therapy and less of local therapy. So I have covered approximately 30 slides so far. In my last 30 minutes, I will just try to summarize what is the message that I'm trying to give you all. My first message is that all cutaneous lymphomas are not mycosis fungoides. We must try to identify and classify cutaneous lymphomas well, T cell, B cell, CD30 positive, CD8 positive, CD4 positive. That is first step. Second step is thorough clinical examination and documentation of the disease. Third message is read and discuss pathology and IHC reports well with your pathologist and try to correlate them with the clinical findings. T cell receptor rearrangement is a problem solving tool which can be easily used whenever you're in doubt. All mycosis fungoides patients do not require radiation therapy or TSET. You have to judiciously select which patient needs what therapy. Chemotherapy largely does not work, and CHOP certainly has no role. If you have big lesions, ulcerated lesions, thick lesions, start treating them first before starting with total skin electron therapy. So now I'm coming to the second part of my presentation, which is about radiation therapy, role of radiation therapy in the treatment of mycosis fungoides. And with a lot of pride and conviction, I say that radiation therapy is the single most effective modality in the treatment of mycosis fungoides. The earliest treatment of mycosis fungoides or the skin lymphoma has been reported as early as 1902, where ortho-voltage X-rays were used. If your patient has early disease, you may give just a patch treatment. While TSET is a specialized technique where we are giving electrons to the entire skin surface with limited adverse systemic side effects. So these are two pictures. This is the patient at presentation. You can see these thick lesions, and this is the same patient midway through his treatment. So I am sure you must also be having the same conviction now as I am having. Radiation therapy works well for these patients. This is another picture which I showed you some time back. Ulcerated lesions. Look at the condition of the skin. He had edema all over the skin. I was very scared to treat him. And look at his legs after about 3 to 4 months of completion of therapy. Look at these scaly lesions on the feet and look at the clean feet later on. Radiation therapy is a very, very effective treatment modality for mycosis fungoides. So as I mentioned just now, if your patients have stage 1 disease, they just need localized radiation therapy. Generally, the recommended dose is more than or equal to 30 gray total dose. Because malignant cells of mycosis fungoides have little ability to do a sublethal damage repair, there are no issues with the use of low dose per fraction. And generally, you should use liberal 1.5 to 2 centimeter margins around the visible or palpable lesions. Now let's come to total skin electron therapy. Now let's come to total skin electron therapy. There are several methodologies of doing total skin electron therapy. A lot of institutions there develop their own technique of delivering total skin electron therapy. But the most widely used one is the one which was developed at Stanford. It is called a Stanford technique of 1960s. And it has been later on modified several times. So I find that majority centers across the world, to my information, use modified Stanford technique. And the indications of TSET are non-localized mycosis fungoides, especially stage 1, B2, stage 3, they benefit with total skin electron therapy. Now let's pay attention to the treatment geometry for total skin electron therapy. This is very important. Please listen carefully. So we generally use 4 to 6 MeV electrons can be used from linear accelerator. Preferably, linear accelerator should have a high dose electron mode where it delivers 2500 MUs per minute so that patients can complete treatment faster. If you look at the older generation of linear accelerator, the usual TSET mode had 800 MUs per minute. But the current generation gives you a faster treatment. 2500 MUs are delivered per minute. There are angled dual fields. So this is superior field, this is inferior oblique. So patient has to stand on this TSET frame, which is kept about 3 to 5 meters from the linear accelerator head. Depending on the size of the room, you can choose an appropriate distance. Generally, there are two gantry angles, which is 17.5 degree above and below the beam axis. And then there is a perspex sheet. This is the perspex sheet, which is placed in front of the patient. The aim of placing this perspex sheet is to attenuate as well as scatter the incident electrons so that 4 MeV electrons reach the skin surface. Please listen to this carefully. I will explain you this diagram. So first thing is that when the patient is placed behind the perspex sheet, patient is not touching the perspex sheet. In this, they have recommended a distance of 27 centimeters. You can choose your own distance. the distance has to be anything above 15 centimeters. The idea is so that the electrons scatter and reach the skin surface and they attenuate also well. But whatever distance you choose, the same distance has to be kept during the dosimetry as well as real patient time treatment. Now, when we see the patient setup, we make sure that the central axis is passing through the center of the body. The patient should not be on the left side or right side of the beam, and the central axis of the beam generally is kept at the level of umbilicus. Now let's look at the two beams. This is the inferior beam, 287.5 degrees. This is the anterior border of inferior beam. This is the central axis, and this is the posterior border. So the central axis of the superior beam ideally should graze through the feet of the patient, while the central axis of the inferior beam should go above the head of the patient. If you are able to achieve this, then generally you will find that the Bramstellan X-ray production leading to bone marrow toxicity is far less. Now, you can adjust your beam angles, gantry angles, to make sure that this central axis grazes through the feet and this central axis grazes above the head of the feet. But your physicist will not allow you to change the gantry angles very frequently, because they would have done dosimetry at certain gantry angles. So what we do commonly is that we have 3 of these pedestals. Depending on patient's height, we keep moving the patient up or down, so that the central axis of the beam is passing through the umbilicus, and this is grazing the head and this is grazing the feet. Now, another very important thing is, you see this is the inferior border of upper beam, and this is the superior border of inferior beam, and then there is a gap. So when you're checking the setup, you have to make sure you open the field light, and you have to make sure that there is a gap of 15 to 20 centimeters where there is no field light. Beams should not be overlapping. There should be a gap of 15 to 20 centimeters, because this area of gap will actually get the scattered electrons and will still be well covered. Having treated many patients, we have always managed to put a lot of gas chromic films or MOSFETs in this area, and we find that this area, in spite of there being no beam overlap or practically no beam, gets adequately covered with electrons. If your beams are overlapping, then this area will actually get overdosed and your patients will have a lot of skin reactions. I hope I'm clear on this. Another thing, the thickness of the Perspex sheet. They have recommended 3.2 millimeter. I think let your physicist choose a appropriate thickness of the Perspex sheet, depending on the distance that you have from the gantry head to the frame. We generally use a 5 millimeter thick Perspex sheet. Now let's look at the treatment positions. So these are 3 different positions. We generally give a printout to the patients. We give them training sessions so that they understand how they have to stand. The idea of maintaining these different positions during treatment are so that there is maximum unfolding of the body. For example, if the patient is standing like this, the axillas are getting treated. If the patient's hands are sagging, the axillas will not get radiated. Look at this position. In this position, the axilla here and here are getting exposed. Medial aspect of the thigh is getting exposed. One leg is not shielding the other leg. So we are trying to avoid shadowing effect or shielding effect, and we are trying to unfold the body in these positions. So these are the positions which we maintain on day 1, which is anteroposterior, which means the patient is facing the gantry, and 2 posterior obliques. On day 2, generally the positions are reverse. It is posterior direct PA view, as well as 2 anterior beams are given on day 2. So on day 1, patient gets radiation to these 3 during 3 positions with both gantry angles, superior as well as inferior. On day 2, patient gets these 3 positions. So eventually over 2 days, the entire body surface area gets covered. For example, on day 1, when we were treating the patient in these 3 positions, some part of the posterior lateral aspect of the body gets underdosed, which gets covered on the next day. It is little tricky to understand, but I hope I'm clear. If you want to start TSET in your department, first thing that you have to do is that you have to discuss with your physics. You have to check if your LINAC room is big enough to maintain a distance of 3 to 5 meters between gantry and TSET frame or not. You have to check whether you have a TSET mode in your LINAC or not. And then you have to get a TSET frame. And then you have to start with the dosimetry or commissioning. Dosimetry, commissioning, etc. easily takes a month, unless your linear accelerator is absolutely free. So you have to do a lot of preparation before starting the treatment. Just wanted to share some words about the kind of TSET frames. There are several kind of frames which are available. There are rotating frames also which are available, where the patient does not have to change the position. You just rotate the frame and the patient gets rotated. It is a good idea that the frame should have some support for the hand, especially for elderly patients. And these are some of the pictures of commissioning of TSET which I wanted to show. So this is our linear accelerator. So this is the frame. So here they've kept phantom at the level of head, at the level of mid body, at the level of legs. At all levels, physicists will do dosimetry and come out. Similarly, they will also look at, they will place ionization chambers and chromic films at various depths and assess the depth to which the electrons are penetrating. And finally, they will give you this combined 6 field 2 days cycle का जो final PGD आएगा, they will give you that. Through this PGD, you can see where your 80% dose is falling and where your 20% dose is falling with respect to the skin surface. I will come to it once again also. So there are some very good EORTC recommendations on TSET dosimetry. It says that dose inhomogeneity at treatment distance should be less than 10% in vertical and lateral plane. This is what I mean. So if you look at it from in the vertical plane, the dose inhomogeneity should be as low as possible. Preferably, it should be less than 10%. It also says that the 80% isodose line should be more than 4 millimeter deep to the skin surface. So at least 80% isodose should cover up to 4 millimeter of deep to the skin surface to ensure that epidermis and dermis are adequately treated. At the same time, we have to make sure that 20% isodose line should be less than 20 millimeter from the skin surface to minimize the dose to the underlying structures, especially bone marrow, etc. So this is how you interpret it. This is the PDD which we got from our physicists, medical physics team. They showed us that this is the 80% line, and if you connect it here, it is lying somewhere at 6 millimeter from the surface, while 20% isodose line is lying at around 16 to 17 millimeter from skin surface. So this gives you a confidence in saying that your dosimetry is well. Ideal aim is that total dose to marrow from photon contamination from Bremsstelling X-ray production should be less than 0.7 gray, and we use internal and external eye shields to minimize the dose to the eyeball. Now, some practical tips from my side. So whatever parameters, for example, location of frame, gantry angles, perspex thickness, distance from perspex to phantom, you follow while commissioning the TSET, same have to be followed later on while doing the treatment also. We have marked the position of frame on the floor so that there is no discrepancy on that. Make sure that the central axis of the beam is passing through the center of the frame and the center of the patient's body. It is a good idea to do 1 or 2 rehearsals of positionings before actually starting the treatment. And patient height has to be adjusted. I have already mentioned it. Now let's come to the shielding which is required during TSET. So common shieldings which are required during TSET is, first of all, you require an external eye shield. So what we have done at our center is we've just got one goggles, little oversized goggles, and we replace the glasses with lead shields. Once you're replacing the glasses with lead shields, the goggles actually become quite heavy. So you need some Velcro kind of tape to fix it to the head so that they should not keep falling. And we use it in all fields. For example, somebody can argue that why do you need goggles in posterior oblique fields? You still need it because there are scattered electrons. If you will do dosimetry, you will find that the dose still reaches there. And while doing a film dosimetry, it is a good idea to apply few films below goggles to check the doses. You need to apply some shielding on the hand and toenails every day. You have to shield the root of the nail. You don't have to shield the tip. You must remember that. You will also require some internal eye shields for treating the eyelids, as the eyelids get shielded with your lead goggles. For a male patient, you will require some testicular or scrotal shield also, especially if they do not have any lesions in the scrotum or perineal areas. It can be made locally by using the scrotal guard, which is usually used in sports, cricket, etc., and suitably cover it with lead and wax. You don't really have to worry in women about ovaries because ovaries are deep seated inside pelvis, but young men who are getting TSET and who want to preserve their fertility need to be suitably counseled and sent to fertility specialists before starting their treatment. This is a picture from TMH. This is not our picture. So this is the scrotal card. And sometimes if the patient gets a lot of reactions on hands and feet, you need to shield them also. So this is the hand glove and this is for thumb. These are the nail shieldings which have to be applied every day on the patient. This is one patient treated long time back. When he had come to us, he did not have any lesions on the eyelids. So we just treated him with goggles. That time we were not using internal eye shield. 6 months later, he came back to us with lesions all around the eyelids. It was a big lesson for us. And now we routinely treat our patients. After having treated them with goggles earlier, we apply internal eye shields and give radiation to 20 to 26 gray, sometimes even 30 gray, depending on the disease dose to the eyelid area also. Now, another small point which nobody talks about is it is very difficult for patients to stand in the treatment room with so many of us, doctors, physicists, technologists, nurses, everyone around, and it is very difficult to stand for patients without any clothes. I incidentally found one paper from the ASTRO meeting which had compared skin doses in for TSET with or without clothing. So what they did was they just put their hospital gown over the phantom and calculated the doses, and they found that the doses on the surface of the phantom were not very different. So now we have routinely started using a thin cloth. This is not our patient's picture, but we give them a very thin cloth, which just covers their body reasonably well so that the patients feel comfortable. And when we've done dosimetry, we've not found any problems in the dosimetry or response to treatment. As I mentioned earlier, if your patients have a lot of thick lesions or ulcerated lesions, it is a good idea that you start treatment with the boost field first and later on start with the total skin electron therapy with appropriate use of the bolus or the skin degrader. This is another of our patients. So we started, you can see 6, 7, 5, 10, all these numbers are there. It is a good idea to start with the boost first and then TSET. In vivo dosimetry is essential. Whatever dosimetry your physicist may do, you still have to, every patient is different. They are not phantoms, they are patients. They have irregular body surface area. For example, this gentleman has a big belly. I'm very concerned about, when I place him in front of the frame, his distance of forehead, chest, abdomen, thighs, it is going to be different. It is not a flat body, it is an irregular body. So you have to place either TLD batch or gaphromic films or apply MOSFET at multiple positions, apply them for 2 days, and then take a combined reading to understand what is happening to which area. So this is the kind of picture, this is the kind of dosimetry, in vivo dosimetry, which our physicists share with us. This is the dose which has gone on day 1. This is the dose which has gone on day 2, and then you look at the combined doses. It gives you confirmation of doses. You also know whether you are maintaining the homogeneity of around 10 to 15% across the body or not. And sometimes if they are getting overdosed or underdosed, then the patient position has to be adjusted in relation to the perspex sheet. If there are selected areas, you will identify that, okay, my hand is getting overdosed, so let me shield my hand in the last 4 fractions, or probably this area is getting shielded, so let me give a boost. So in vivo dosimetry is an essential part of every patient's treatment. It helps you individualize their treatment. Now let's come to dose and fractionation. We've completed about 50 minutes of the presentation. Mycosis cells have little capacity for sublethal damage repair, so you can choose your fractionation. I will tell you what we do, but there are several fractionation schedules which are available. What we follow is that we treat all our patients with modified Stanford techniques, 6 MeV electrons, high dose rate. We also do their in vivo dosimetry. We give a dose of 30 to 32 gray in 30 to 32 fractions, followed by patch treatment. We give 4 fractions per week. If required, we give a planned break of 1 to 2 weeks after 4 to 6 weeks of treatment. This is how our treatment cycle is. So on day 1, patient gets AP, RPO, LPO positions. On day 2, patient gets PA, RAO, and LAO positions. Dose per day is 1 gray. So day 1, patient is getting 1 gray to these areas. Day 2, patient is getting 1 gray to these areas. Day 1 and day 2 together is called as one cycle. So dose per cycle is actually 2 gray. So over 2 days, patient gets 2 gray to the entire surface of the body. We give them 4 fractions per week, 2 cycles per week. Total cycles are 16 to 18. We are getting little more courageous. Now our doses are 32 to 36 gray. Now this 1 gray per day is URTC recommendation. There are several other fractionation schedules, but I find that this schedule is very nice and not at all toxic. I will say not at all toxic. There are hardly, I will show you the side effects also, but very few side effects and very easily manageable side effects with this kind of schedule. But if I have a patient who has an issue of time, sometimes I treat them with 3 gray per cycle also. And sometimes if they have a lot of time issues, I start with either in the first phase of the treatment or second phase of the treatment. I sometimes even treat them 6 days in a week, so to complete treatment faster, but it is a easily reasonably tolerable treatment. So something about positioning. I'm sorry, these pictures are not correct. These pictures were taken while we were uh, teaching patient how to stand on the frame. So that is why you will find that the goggles are missing in these 2 positions. So this is day 1 position. So this is day 1 AP, and these are posterior oblique position. Fingers have to be spread out so that the radiation doses go between the fingers. Head has to be slightly extended. It has to be slightly extended so that this part of the neck does not get shielded. Arm has to be at the level of shoulder or slightly raised up so that the axillas are exposed. Feet have to be widely separated so that the medial aspect of the thigh gets treated and the feet are not shielding each other. It is a good idea to tell your patient that this knee has to be slightly flexed so that this V area gets exposed. So pay attention to these small points for a good delivery of radiation therapy. We use finger and toenails for all our patients. We use external eye shields, internal eye shields. Now coming to the boost. Sole of the feet does not get any dose, so we give them 20 gray in 10 fractions. Perineum does not get any dose. We give them 16 to 20 gray total dose over 10 fractions. Pay attention to undersurface of the breast, especially if the patients have pendulous breast. The inframammary crease gets underdosed. If they have big belly, it is difficult to treat patients with big belly. There is a lot of dose inhomogeneity. You have to treat undersurface of the belly with suitable doses. Eyelids have to be treated. Axilla has to be treated. Scalp, the top vertex gets underdosed, has to be treated. Sometimes if there are lesions in the upper medial aspect of the thigh, it will also require additional boost. I will show you some pictures. So this is how we treat the sole of the feet. We make them lie down and there is a direct and facing beam. We generally use a degrader or bolus. And if there are any lesions in the axilla, you have to mark it out and treat it. Similarly, this is showing perineal port and this is the area of the perineum which gets underdosed and has to be treated with total skin electron therapy. Patients will require some additional care while they are on total skin electron therapy. The most important is adequate hydration. They have to be encouraged to drink enough fluids, enough liquids to prevent hyperuricemia. I generally tell my patients to be on high protein diet also because there is a lot of scaling which is happening while they're on radiation therapy. So by scaling, they lose out a lot of proteins. I encourage them to maintain their moisturization of the skins. They have to wear light, loose clothes, soft shoes. They require more care if they have earlier received chemotherapy or Cuba therapy where the skin is already, you know, not so healthy. I ask them to avoid sun and use a big hat to protect sun exposure. We do weekly blood tests for them. If there are any skin infections, we try to treat them promptly. We generally involve one dermatologist in their treatment for asking for suitable help. If they have too many side effects, then consider giving them 1 to 2 weeks break. Now, these are some of the pictures which are showing the acute toxicities. For example, you can see that there is a nail dystrophy which is happening while the patients are on treatment. It is common to have bullas on the skin, you know, but not to worry. They are self-limiting. They heal within a week or two. The patients can get some pruritus, dry desquamation, erythema. Everyone gets alopecia, but it is a reversible alopecia. They will get dryness of the skin. They get bulla of the feet. Around 10% of the patients will have edema of hand and finger. They can have self-limiting gynecomastia. They might get mild epistaxis. One of my patients, she got very angry. Day two, she came. She said, "You never told me that I will get epistaxis. So it is a good idea, that even if the incidence is around 10%, you let your patients know." I find that patients who have received earlier PUVA therapy, they get more skin toxicity. Patients who have earlier received chemotherapy, they sometimes get hematological toxicities. But so far, none of our patients have ever been admitted with any acute toxicities. And these are some of the pictures. For example, this gentleman had a superficial skin deformation here. This is the common pattern of alopecia. I look forward to this pattern. So you can see that this patient was a sick. He had big hair. Now, only the vertex, the top part of the head is where the hair are remaining. So I give a patch treatment here, understanding that this area has got underdosed. Some patients get edema of hand and feet. If they get it, then you have to suitably cover them with a glove or a mitten, to avoid overdosing in this area. If there are any doubts, then sometimes midway during the treatment also we do additional dosimetry. We've applied films all over the leg and feet because he had ulcers over here and we had already given him a dose here. This patient did not have hair earlier. So I was not sure, which area to boost. So we applied some films. You can do a dosimetry and define your boost area accordingly. And as I mentioned earlier, for patients who have advanced disease, TSET alone is not enough. You have to give them combined modality treatment, be either in the form of PUVA A or PUVA B or topical therapy. I find that oral methotrexate 15 milligram once in a week for 6 to 12 months as adjuvant therapy is quite useful in preventing reoccurrence, especially in the advanced kind of tumors that we see, ulcerated tumors, nodular tumors, extensive disease. It is very helpful. There is a newer concept which talks about low dose total skin electron therapy for cutaneous lymphoma. In fact, there is enough data. By low dose, it means around the dose in the range of 8 to 12 gray. Median dose is 10 gray. The advantage of low dose TSET is that it is a shorter treatment, reduced cost. The compliance is better. There are less side effects. Re-radiation is easily possible, but I do not use it. I did a lot of literature review and I have seen some of the patients who have earlier been treated with low dose TSET. What I find is that the disease reoccurrence is very fast. We are in India. Salvage is not only clinical salvage or disease salvage. There is always a financial salvage. There is always a social salvage associated with any kind of salvage therapy. If my patients have to come back very often, 6 months, 9 months later, they have to come back for a re-radiation. It is not easily doable. We don't have so many resources. So I'm happy doing 30 gray, although science is evolving and I might also change over a period of time. Now let's talk my last few slides, Rashi. I'm just winding it up. So my last few slides are about re-radiation. Since radiation dose in cutaneous T-cell lymphomas is not very high, re-radiation in small fields is easily possible. For example, you've given TSET to somebody and he gets a small recurrence over hand, feet, leg, etc. You can always do a patch treatment so that they're symptomatically better. There is reasonable literature about re-TSET also. You do TSET now and you repeat it later. So if the first TSET was with low dose 10 to 12 gray, then re-TSET is much easier and can be done anytime after 6 months from the previous TSET. If the first TSET was high dose, for example, 30 gray, then also a re-TSET can be done after a gap of 1.5, 2 years. And generally the dose is 10% lesser. You can give a dose of 26 to 30 gray. We have so far done 2 or 3 TSETs and we did not find much toxicity in repeating this TSET for these patients. This is just, some special situations. I have not done it myself, but just to share with you that if you have a small child, then you sometimes need to modify that. There is literature about infants being treated with total skin electron therapy, either in the form of tremor or the patients are made to lie down on the couch top or on the floor for total skin electron therapy. Similarly, if you have a very debilitated elderly gentleman who cannot stand, then there is some literature which says that you can make them lie down on the floor and do their treatment. Although, please speak to your medical physicist because they will have to do dosimetry in these difficult positions before you actually start it. It is a teamwork. The majority, I have been with Max Hospital for last years, although I have changed my branches within Max Hospital. So, uh, total we treated about 25 patients. In my present center, we treated 7 patients. It is a teamwork with physicists, doctors, technologists, nursing staff, even ward boys, ward ladies. All of us have to come together for delivering this treatment effectively. And since I knew that these slides are going to be shared, in the end, I have put some screenshots of the important articles, very relevant articles. If you want to go through these articles, they will help you understand this concept better. And I hope I was able to deliver the required information to you. And if there are any questions, Dr. Asmita, then I'm happy to take. Thank you.
First of all, thank you so much, ma'am, for a very elaborate presentation on a topic which most of the radiation oncologists, even if practicing for a long time, are less versed with.
Smita, your voice is not coming clearly.
Ma'am, okay, I will disconnect it. Thank you. Ma'am, am I audible now? Am I
Yes,
audible?
better now.
Okay, ma'am. First of all, thank you, Vineeta, ma'am, for such an elaborate presentation on a topic which is often less clinically touched in the clinics as well during the PG curriculum. And it was a very elaborate presentation, starting right from the clinical presentation, the diagnosis, and encompassing also the clinical dilemmas you encountered. And it's a very thorough lecture, and I hope we all gain from it. It was really a very wonderful presentation, ma'am. And ma'am, shall I take the questions now?
Yeah, start please, ma'am.
Okay. So, ma'am, this is question from Dr. Anu to everyone. How do you do the internal eye shield? And ma'am, summing up, what are the internal eye shields are made of?
So internal eye shields have actually a lead lining within it, which is I don't know of what acrylic material they are made of. They are commercially available, and you have to put some xylocaine drops. It comes by the name of paracaine in the eyes of the patient, so that the eyes are have a local anesthetic effect, and then you just apply them. We women we use contact lenses. Similarly, you just apply it to hold it in place. Sometimes we put micropores on both the sides so that, and we ask the patient to look at ceiling, so that they do not slip medially or laterally.
And there was also a picture, ma'am, you used in the presentation. It
Yes.
shows eye shield.
Yes.
You showed the picture as well.
Yes.
And ma'am, the second question is from Dr. Pami Srivastava. What is the depth of treatment in TSET and why are the nails shielded? And what is the side effect on nails if they are not shielded?
So the depth of the treatment in TSET is usually from skin through 4 to 6 millimeter deep. Nails are shielded. Actually, the nails do not have to be shielded. You have to shield the root of the nail so that later on the growth of the nail continues. If you do not shield the root of the nails, then the nails may not grow back. That is why you have to shield.
And now one question from Dr. Bala. What is the energy of the electron being used?
So you have to choose an appropriate energy of electrons with your particle physicist. Preferred is 4 to 6 MeV electrons. You will have to choose an appropriate energy depending on your room size and distance from gantry to frame. We use 6 MeV electrons. Our treatment distance is 3.2 meters. At 3.2 meters, the frame is kept. So the effective energy and then there is a degrader. So the effective electron energy which reaches the skin surface is 4 MeV. With 4 MeV, with this kind of setup, we are able to give 80% dose at a depth of 4 to 5 millimeter, and at 20 millimeter or 2 centimeter depth, there is only 20% dose. So you have to achieve that optimum dose to the skin and up to a depth of 4 to 6 millimeter with a rapid fall off. And the ideal energy is 4 to 6 MeV. But for the boost treatment, for example, I showed you one patient with very thick nodular lesions. There we used 9 MeV electron. We were actually thinking that we would require 12 MeV, but 9 MeV was sufficient.
Ma'am, there is one more question from Dr. Shrikant. Do you use any fixation devices for accurate reproduction of treatment position? And if so, can you explain?
We have when we this frame which we have was locally made. So in the initial phase when we were making the frame, we had created one rod. On the top of the rod we had put the cycle seat, small cycle seat, so that if there are patients who cannot continuously stand, the height of this cycle seat was adjustable, so that for patients who cannot maintain their standing position for a long time can get some support. But it did not work well. Right now there is only one support fixation system that we use, that is there are two bars which are hanging from the top, and the patients are allowed to hold them, especially patients who are unstable. Otherwise our frame is actually not a very, it is a very crude kind of frame. We need to really
And
improvise on our
one
frame.
last question from Dr. Rashi. What are the side effects of TSET?
So as I have mentioned, the main side effects of the treatment are the patients will lose their scalp hair, they will get alopecia, they might have some itching, they might be, the patients become very dark by the time they complete their treatment. They have a lot of pigmentation, but then this pigmentation recovers well within 1 to 2 months after completion of the treatment. The development of skin bulla or moist desquamation is only patchy, not very confluent, and only 10% patients get it. Generally, if your setup is good, which means then there is less X-ray production, or when there is less X-rays being absorbed in the body, I don't find any hematological toxicities. They will lose their
Ma'am, one
nails
last
also,
question.
but then the nails also grow back.
Ma'am, one last question from my side. Do we use scalp shielding? Is scalp shielding used? If the scalp is not involved, so is it preferable to use scalp shielding?
So that depends on the extent of the disease. So if
Okay.
you have a patient who's very desirous of, he or she does not want to lose the hair, and there is not so much of disease around the head and neck area, then you may shield the scalp after explaining to the patient that if some lesions reoccur in this area, then he or she will require additional treatment.
And ma'am,
But I get only very advanced kind of cases, because these patients, they get a lot of time before they actually get a diagnosis of mycosis fungoides. And then everyone gets CHOP chemotherapy in medical colleges before they come to us, or PUVA therapy. PUVA therapy is fine, CHOP is not fine. So they usually have so much extensive disease, or they're coming from far off places where they say it is impossible or difficult to come back. So that I have so far not shielded scalp for any of the patients. But if you have such a case, then you may do that.
thank you, ma'am. Thank you. And any more?
Yeah, ma'am. I think
One more.
this webinar can end abrupt anywhere, but there are questions. I think we should ask this opportunity to ask ma'am questions. Dr. Asunda, you can continue. The question is, next question, what is the cost? Dr. Neeraj Stogis ma'am is asking, what is the cost of TSET at your center?
And this is getting recorded.
Sir, please ask, sir, I can share ma'am's number. Dr.
The cost is, I don't remember the cost honestly, but the cost of the entire treatment, boost, ये वो सब मिला के, I think is roughly around 2 lakh rupees.
Just a last question I would like to take. When someone is asking, what about the lesions inside the external auditory canal? Any specific field or something?
So, I showed you one picture. One patient had lesions within the external auditory canal, and I thought that we will give it a direct electron boost, but after TSET only it disappeared. So generally, if it will relapse, then I will treat it, give some extra dose. Otherwise, no additional dose is required.
Yeah, one more question. Can we use antibiotic eye drop or artificial tear drops while
Yes.
using internal eye shield?
Yes, it's a good idea to use it.
And what is the use of perspex sheet in front of patient? I think you have already explained this. What is the
Perspex sheet is used so that the electrons get scattered. You are trying to cover a big area, right? And the second is so that there is attenuation of the energy, so that the dose reaches the skin surface.
Yeah, and uh, what is the dose rate that you use for electrons?
We use the HDR high dose rate electrons, 2400 MUs per minute.
And any specific material for pedestal?
No, no, no. Wooden pedestal. Our carpenter only made it.
Ma'am, one more thing I have seen, uh, the drawing of feet when we
Yes.
treat the patient. Yes, that was very important, I think.
Yes. So what we actually do is that we make two drawings. We are actually right now we are treating two patients with TSET. So each day, every patient has a specific sheet which has to be kept under his feet, and the position of the feet is marked. So that positioning is very quick. Earlier, we used to take 1 hour to treat every TSET patient. Now we finish it in between 20 to 30 minutes because with time we have learned how to do it. Somebody is asking about role of tomotherapy, so let me explain that. Tomotherapy as such does not have a role. Why? Because there are photons. There are no electrons in tomotherapy. But if you have a patient who has DLBCL, not T cell, but diffuse large B cell lymphoma of leg, then there are some patients which talk about using IMRT because there you have to cover the entire circumference of the feet, of the leg. So what you can do is that you have to wind polars around the entire circumference of the leg, and then you can do IMRT for these patients.
Any more questions?
Yeah, I don't think.
Ma'am, I think the session can end at any time.
Yeah.
It's already 11:19, ma'am. So
I would like to thank everyone.
ma'am
I
for
would
a
like
very
to thank
wonderful
everyone
session.
for who's
Very
attending the
wonderful
session.
session,
And
very
thank you,
innovative.
Dr. Rashi and Dr. Anu and Dr. Asmita.
And
It
I would
was such a nice presentation. It was really one of the best webinars we had. So thank you very much, ma'am.
Thank you so much, Dr.
and
Anu.
thank you, Dr. Anu, ma'am, for organizing such wonderful webinar.
Yeah, one more thing from my
Thank you,
side,
ma'am.
radiation oncologist should not fear from medical oncologist. है ना मैम?
हाँ, बिल्कुल नहीं.
हाँ, हमें अपनी बात कहनी चाहिए. I have learned all these things Dr. Vineeta मैम कि हमें मतलब ऐसे पेशेंट्स को ट्रीट करना है. वो लोग चॉप दे रहे हैं, कीमो दे रहे हैं, एंड वी यूजुअली फियर कि साइड इफेक्ट्स आ जाएगा तो क्या होगा. एक्चुअली जो हमें फियर होता है वो साइड इफेक्ट का होता है, और जो मेडिकल ऑन्कोलॉजिस्ट डरा देते हैं कि सारे साइड इफेक्ट रेडिएशन की वजह से है. Thank you, ma'am. Yeah, so I think I am closing this webinar. Thank you so much, ma'am. Thank you. Thank you, Dr. for moderating the session. Thank you, Dr. Anu. Thank you, everyone. Thank you, ma'am.